For this WCLC 2022, I can maybe stress some highlights. More importantly than ever, I think this meeting is characterized by a very interprofessional environment, which is quite interesting because it allows us really to discuss what we know as medical oncologists in the context of a multidisciplinary approach. Thinking about it, the highlights maybe of this Congress, the most important data come about the adjuvant or neoadjuvant trial using immunotherapy, so the curative setting, the early disease. We have been seeing during the best abstracts selected, among these best abstracts, the overall survival data, the first interim analysis for survival in the IAM-POWER10 trial. IAM-POWER10 trial is evaluating the pure addition of atezolizumab in patients having received adjuvant chemotherapy and a full resection of the tumor stage 1B to stage 3A. This is the first, of course, reading, but it's already showing that in this subgroup where we can give atezolizumab in Europe, meaning the patients with more than 50% PD-L1 as per EMA registration, we can decipher and identify a benefit in survival. Again, it's an early reading, so it's going to even change over time and potentially improve. In the whole subgroup of patients of more than 1% PD-L1, which corresponds to the US registration, the FDA, I would say, registration of the drug and the strategy, we can see already a trend. It's probably not very far from being significant with some more observation time. So what I mean by that is we start to see from that trial in the adjuvant setting that it will translate probably, maybe in subgroups, into a benefit in survival like we have been seeing in the past with the adjuvant chemo. So we have to stay tuned, but it's a very good signal in order to really change the still quite poor outcome of our patients treated with surgery in early disease. We also could see phase 2 data from the NADIM trial. I don't know if you remember the NADIM trial. It was chemo versus chemo IO in the neoadjuvant setting in stage 3A, so a disease characterized with a very high relapse rate of almost 70%. And in that trial, of course, it's a phase 2. It's a small trial with wonderful results in terms of PFS in favor of the chemo IO induction versus chemo. It was showing at this meeting, again, a benefit in survival. So, of course, with the limitation of a phase 2 and a small sample size, we, again, can conclude that immunotherapy in the early stage will translate probably in benefit in survival. Here is stage 3, so in this subgroup of stage 3A. Remember, we had in the past a larger trial, the CheckMate 816, which was presented at ASCO and AACR, nivolumab plus recycle of chemo in a larger cohort of patients, stage 1B to 3A, also registered like that by FDA. And remember, when we saw the early survival curve, it was pointing out already that survival might be met after some more events. So really kind of a consistent data set. Going out of the immunotherapy, I think we have been refining how to use immunotherapy. Out of the early disease, we've been seeing how to use immunotherapy in more refined subgroups of patients. And we have the pleasure to present some, again, data about efficacy of combination with anti-PD-L1 and CTLA-4 in patients with the famous STK11, KEAP1, and KRAS mutations. So things which have been shown already by 9LA, 227, MYSTIC. But now we have the opportunity at this meeting to show it in Poseidon, the strategy of CTLA-4 in these subgroups of patients who usually have a poor outcome in general and under IO. And last but not least, surgery. We had a Japanese trial showing that surgery can be minimal, meaning segmentectomy in tumors less than 2 centimeters. It was already published in the past, allowing our surgeons not to do lobectomy, not to do pneumonectomy when the tumor is small, of course, without lymph node negative, without lymph node infiltration. We had here an American study confirming the Japanese data. We always like to do that. Surgical techniques are slightly different. And this trial was showing that in less than 2 centimeters and zero tumors, you can replace lobectomy by segmentectomy or by wedge. Segmentometry or wedge was led to the investigator, but really showing an equivalent survival. So simplifying the surgical setting for these patients.
How about Swiss participation and studies?
Well, Switzerland has been participating in many of these trials. Of course, not the NADIM, which was mainly Spanish, but I think Switzerland is taking part more and more to these neoadjuvant and adjuvant studies. And I would probably say that Swiss delegates were very present. I could meet many of the colleagues here in order to exchange and refine our practices in Switzerland. But we are deeply involved in the setting of immunotherapy in general, but neoadjuvant and adjuvant have been largely kind of conducted also covering Switzerland, which is very good.